Hello, everyone. Good afternoon. Welcome to this session. My name is Dr. Yehuda Marte, and I'll be chairing this session. I think I was hoping for a fuller room, but hopefully it gets more full as we go along. But today's session is really focused on antimicrobial resistance, and I think it's such an important topic that we are discussing here today. So our focus is really thinking about how antimicrobial resistance is impacting the cancer community. I think we don't think about that enough. We don't talk about that enough as a cancer community. And the goal is to think about how we as a cancer care community can come together and mobilize efforts to address AMR. So I am going to define what AMR is because I've had at least one or two people say, what is AMR? So antimicrobial resistance, as most of you in this room know, is when the microorganisms that cause different infections, whether it's fungus or viruses, develop mechanisms that allow them not to respond to antibiotics anymore. And so when this happens, we have patients who are on antibiotics but no longer respond because the organisms have developed ways to evade the effects of the antimicrobial agents. And when this happens, we have acute complications of infections, but then we can also have fatal outcomes. And so I think the goal here is to really focus on how this is impacting the vulnerable population, the few, but really the cancer community at this session. And so, I think WHO has rightfully highlighted AMR as one of the top 10 leading causes of one of the top leading causes of public health emergencies in currently being faced by the world. I don't think there's been as much focus on the cancer community. So I'm going to get us started with a video, and then I'll invite our panelists to give brief presentations. Click again.
I was 33 years old when I was diagnosed with cancer for the first time. The chemotherapy that was used to treat my cancer, it was very, very strong. I was very, very susceptible to any type of infection, and any infection could become very, very severe and kill me. I couldn't have gone through that treatment without antibiotics, without effective antibiotics being available to me.
So antimicrobial resistance occurs when the drugs that we give to fight infection are no longer effective, and sometimes patients can die as a result of antimicrobial resistance. Cancer patients tend to be most vulnerable. In places like Botswana, where I am currently, it's even more of a challenge because it depends on what antibiotics is in stock.
Hygiene, sanitation, access to clean water is important, and then also increasing the rates of vaccinations to prevent some of these infections in the first place is critical for addressing antimicrobial resistance.
And I think it's going to be an even bigger challenge for those of us in the cancer community, because how we treat patients who are affected with cancer is going to be severely impaired.
I got cancer, that was bad luck. But AMR is not bad luck. We can prevent it by only using antibiotics when they need to be used. And we can give future patients, future generations, our children, grandchildren, the opportunity to get life-saving treatment.
Which highlights Dr. Christian Mulvin is actually in the audience, but I think, and thanks so much for sharing your story. I think this is unfortunately not uncommon. A lot of patients who are diagnosed with cancer, who go through cancer treatment, actually do get infectious complications. And a lot of them are going to get complications from AMR organisms, so resistant organisms. Actually, 1 in 5 patients with cancer will be diagnosed with an infectious complication during their treatment course. And when we think about the 20 million estimated number of cancer cases that are diagnosed, it helps think about the scale of the problem. And so we have different speakers who are going to speak on the issue in various aspects. We'll start with our first panelist, who is Diane Flayard, who is the Global Program Lead for Antimicrobial Resistance at BD. She works to champion and support the development of new AMR program initiatives in global awareness, infection prevention and control, and antimicrobial stewardship. So we know the negative aspects of AMR in cancer care, and up until recently, the data was really scarce. And so Dan will present some of the data that they've gathered on this topic.
Okay. Well, it's a pleasure to be here. As Yehuda mentioned, Diane Flayhart, focused on AMR and global policy. And today I want to talk about how drug-resistant infections have the potential, and actually probably currently already are, undermining the strides we've made in cancer care. The first session this morning talked about the importance of data and understanding the issue and having data to underscore the risk we're at. And from an antimicrobial resistance perspective, there's been some good data generated over the past few years. You can see here the graph from an article in 2019. It's called the Graham Report. This was one of the probably the first global assessment of the rates of resistance around the globe. It looked at it as a global level, and then it also looked at it as a regional level. And as you can see, it looked at it across the infectious syndrome. So whether it was a lower respiratory infection, a bloodstream infection, et cetera. So here we are able to see the global deaths attributed to antimicrobial resistance. This data really kind of underscored the issue so we could start to understand it. There's also a clear understanding that in children, that 1 in 5 people that are impacted with AMR are children under the age of 5. So this isn't just a problem with the adults, it's also impacting our pediatric population. And one of the clinicians in that paper noted that their biggest challenge in dealing with sepsis in infants was actually understanding how to treat that patient and knowing what organism was causing that infection. These data points have resulted in an SDG target specifically around MDR organisms. So we should measure bloodstream infections due to selected antimicrobial resistant organisms. So now WHO is requiring that this data is being collected. And while we've made strides in how to collect data in general, we have not yet looked to see how are drug-resistant infections specifically impacting vulnerable populations like the cancer community. There's been op-eds that clearly state that tumors aren't the sole responsibility for patients who die of cancer. It's these superbugs that are sickening the patients. There's also been a call for data to be published specifically in oncology patients. So with these calls to action and the lack of data, the Cancer and AMR Consortium was developed. It's a group of oncologists, infectious disease doctors, and organizations working together to find data to understand the issue. And the phase 1 was to really look at the incidence and prevalence of these drug-resistant infections in oncology patients. And how this data was collected was it looked across both gram-negative and gram-positive organisms. So antimicrobial resistance can be in many organisms, but in this study, we looked specifically at gram-negatives to include Enterobacteriales, as well as for those, if there's any microbiologists in the audience, other than me as the microbiologist in the room, what we call non-fermenters. Those are like your Pseudomonas, your Acinetobacters, these really bad bugs that can be highly resistant. And then we also looked at Enterococcus and MRSA, or Staph aureus. And how we defined a cancer patient was to see what chemotherapy, or if they were receiving a chemotherapy. So we're able to say, were they receiving cancer medication, or were they on a cancer location in that hospital? And if it was a yes to either one of those, we then looked to say, did that patient have a resistant infection during that hospital stay? And for the inpatients, we looked at about 4.6 million patients, of which about 6% were defined as cancer patients, And in the outpatient setting, we looked at about 1.7 million isolates, of which about 3% of those were identified as cancer patients. So this is a large data set based over hospitalizations in the United States. So this is a US-based study. And here's the findings. So overall, what we found was a higher incidence of both VRE as well as the gram-negative pathogens. So if you look at that bar chart there, the first column is quinolone resistance. So we wanted to look at, since quinolones are used so much for prophylactic care, for empiric therapy, we wanted to see what does the resistant rate look like. And you can see the top row being the cancer patients, significantly higher rates of fluoroquinolone resistance and gram-negatives. Across the board, whether it's ESBL producers or multi-drug resistant gram-negatives, meaning all the antibiotics or most of the antibiotics were resistant, so there was no choice for treatment. All those were statistically significantly higher. And then when you looked at the VRE, that also was a twofold increase. And while we expect to see higher rates of infection in cancer patients, so we know cancer patients get more infections. However, what this data shows is that there's a twofold increase of resistance. So they're getting significantly more. It's not an incremental same shift in resistance. There's a twofold higher rate of resistance in cancer patients. That was true across all sources except for skin and wound, which were similar. When we jump to the outpatient setting, here you can see the rates were even higher. So there was a twofold increase in AMR in the outpatient. So these were patients that were receiving their chemotherapy in a setting outside the hospital. And even then, and one, the hypothesis is you leave the hospital system, you have lower risk of getting a drug-resistant infection, you have lower exposure. This data clearly shows that for patients with cancer, they still had a very significantly higher rate of drug-resistant infections over their clinic visits over time. Maybe one point before I jump to the conclusion here is that we saw this data replicate itself even at higher rates in sepsis. So specifically patients who had bloodstream infections, their rates were between 2 up to 2.5% higher. So you imagine your most challenging patient with sepsis is going to have a drug-resistant infection twofold, 2.5-fold higher times. So overall, there was an increased AMR rate in cancer patients in both the inpatient and the outpatient setting, which really calls for the need for enhanced infection prevention. So these patients have a lower risk of getting an infection to start with, as well as very focused both antibiotic and diagnostic stewardship. So we're using our antibiotics as carefully as possible for this vulnerable patient population. Thank you.
Yeah, thanks so much, Diane, for sharing this data. I think it's much needed data. We do know that patients with cancer are vulnerable because of immunosuppression from the cancer, but then also from the cancer treatment. But I think having this data highlight the magnitude of AMR is very powerful. I will introduce the next speaker. Dr. Andrea Caputo Sfinzen is a molecular microbiologist and global health advisor at REACT Europe. His work focuses on several European Union and international policy dialogues on antimicrobial resistance, including community engagement, research and development, and cancer treatment outcomes. Andrea is going to talk about optimizing antimicrobial resistance, antimicrobial use for better outcomes in LMIC specifically. Thank you.
Thanks to you. All right, thanks everyone. And today I'm gonna also speak on behalf of our global network, which is indeed sitting in Sweden, where I am, but also in Ecuador, Zambia, and in India. What I wanted to discuss today was indeed what are the challenges when it comes to cancer care in low middle income countries. Here I try to summarize a few of them, but of course this is not a comprehensive list. We can start by saying that one of the main challenges indeed late stage diagnosis and treatment, as well as lack of health infrastructures, including for cancer screening facilities, limited access to medicine, including for antibiotics, and last but not least, a higher burden of antibiotic resistance. Also, to complement what I just mentioned, let's look at this data, where in 2019, only 15% of LMSEs reported comprehensive cancer treatments in public health systems versus 95% in high-income countries. So what are the main impacts when it comes to antibiotic resistance in general, but specifically also in LMSEs? So definitely as a first point is the higher rates of severe infections, mortality, including acquired infections, which means that by going to the hospital and, for example, getting a biopsy, the chances of getting an infection, which is indeed resistance, are quite high. Also, increased healthcare costs and resources. It goes without saying that we're talking about low middle income countries where resources are already limiting. So just imagine what it means when there are increasing costs. Another point is definitely the disruption overall of cancer treatment protocols, which can negatively impact cancer care treatment outcomes. This is a pyramid that we usually show in all our talks at REACT because we think that really summarizes the importance of antibiotics, as we also heard before, of keeping antibiotics accessible but also effective at the same time. And all the key advances are in medicine, including newer immunotherapies for cancer patients, are at huge risk. So we see that when antibiotics are not present, so not having access or not effective anymore, all different treatments and the modern medicine just collapse. So what can be done? Even here, a short list, not comprehensive, but some important, I think, points. It is important to implement both regional, national, and international surveillance systems. So discussing data, as we just heard. Ensure access to effective medical countermeasures, including antibiotics. Strengthen IPC. And last but not least, raise awareness and seek joint action. I want to slightly expand on this last point of seeking joint action, and I was actually very pleased to hear from the previous discussion that Shalini has moderated, discussing a lot about community engagement. And we believe at REACT that engaging communities at local level is extremely important, especially patients. They are key actors in the global response. By involving patients directly, as we also heard from the story before, we managed to humanize the issue. It can drive impact, encouraging other public engagement, highlighting the direct consequences of it, and last but not least, mobilize support and for innovation. I will conclude my talk with one event that we're gonna perform next week in New York during the UN high-level meeting. I know we are gonna hear more about the declaration from John soon. I can just mention that we're gonna have an event. Here, the QR code, I'll show you in a second. During the event, we're gonna hear testimonies, indeed, from communities and civil society representatives on the impact of AMR, and these include also, of course, patients. Then we're gonna have a handover of a call for action. So last April, we launched a call for action that includes 10 asks to governments and member states representative and decision makers from communities and civil societies. And right now, it's actually more than this number that I'm showing here today. So it's over 660 individuals and over 180 communities that have signed the call for action. So we're really proud of that and thankful for everyone who signed the call. Last but not least, there's going to be art exhibition, as I was mentioning before. We believe also that art, it's another form for also raising awareness, and it's quite important for us. Thanks for the attention. Thank you.
Thanks so much, Andrea. I think, as someone who works in Botswana in low resource settings, I think you really highlighted the compounding effect of AMR in resource constrained settings. And I think really it's going to probably widen the cancer outcomes gap that we're already seeing if we don't tackle AMR. Our third speaker is Dr. Terry Roberts. Terry is a public health senior manager in the access team at GARDP. She's a biomedical scientist specialized in infectious diseases and issues concerning resource limited settings, and has worked on global health issues for more than 2 decades in Switzerland, but then also in South Africa. Terry will talk about ensuring sustainable access to quality antimicrobial agents. Thank you.
Thanks. Sorry, I'm so short. Hi everyone, great pleasure to be here. So I'll be speaking on behalf of GARD-P, which is the global antibiotic R&D partnership, and it is a not-for-profit product development partnership for development and access to antibiotics to address the public health needs of drug-resistant infections. So we know that already. Oh, there's no. Should I? I'm so short. This is hysterical. Okay. Oh, try and stand here. I'm 5'4".
Sorry, that was a bad idea.
That was a bad idea.
Oh, that's what it's for. Okay.
All right. For those who didn't hear it, so I'm speaking on behalf of GARD-P, which is the Global Antibiotic R&D Partnership. It is a not-for-profit that is developing products, antibiotics for development and access to antibiotics, and it's to serve the public health needs to address drug-resistant infections. And today I wanted to speak on some approaches that we are taking in AMR that may also be applicable to cancer meds and to cancer programmatically, to see what we can learn from each other. So firstly, touching on push and pull incentives. So these are quite commonly known in the AMR community, but essentially it is these incentives are designed to first push, so input funding and resources to increase the likelihood of development of needed antibiotics to address public health needs, and also to de-risk the investment where another incentive such as profitability cannot be made, such as for antibiotics. And so governments often fund antibiotic research, for example, and this can also be channeled through product development partnerships like GARD-P that can offer additional expertise and resources to facilitate development and also include access provisions. Pull incentives, on the other hand, are more to reward the output, so an antibiotic on the market, and these can be things like prizes, milestone prizes, but also things like revenue guarantees. So some countries, you may know, have subscription models where antibiotics are paid for regardless of the volume. So a manufacturer or a pharmaceutical company will get a revenue guarantee, and this is completely delinked from the sales volumes, and that also guarantees that the revenue is not based on sales, because in that case it's harder to ensure that antibiotics are used rationally and appropriately in the healthcare system. And these two are important, but alone they do not ensure sustainable global access. There's many more things we need to do to ensure access to antibiotics for all people in need. And part of this will be building in access conditions into contracts, for example, into funding agreements, into revenue agreements, that make sure that we can respond to global health needs. So, for example, the WHO published their bacterial priority pathogen list that indicates where drug resistance is needing to be addressed and for which pathogens. And then we can also build on stewardship plans. So that is right from manufacturing of an antibiotic to avoid any antibiotic coming out in the wastewater, entering the environment and the community, but also to make sure that we have the right dosage of the antibiotic and that it is used for the indication in the guideline and that this is enforced. Plus, we can look at diagnostic and antibiotic stewardship in the hospital, in clinics, for example, to make sure the right antibiotic is used at the right dose for the right person for the right amount of time. And finally, build access, regulatory and licensing strategies into the incentive, including voluntary licensing for as many countries as possible to benefit from more affordable generics. However, beyond these push and pull incentives and contractual conditions, what else do we need to ensure access? Well, starting with non-profit drug development, that can be driven by public health priorities rather than profit. Antibiotic optimization and robust uptake led by diverse actors. So, for example, based on epidemiological information for that country, for that region, for that hospital, what antibiotics are needed to address your specific pathogens with your specific bacterial resistances. And uptake, so having country and regional processes in place to facilitate registration and uptake programmatically. And then market efficiencies and transparency, so having procurement that is efficient and harmonized and plus transparent in terms of volumes and forecasting. And finally, licensing for manufacture and access, so again, leveraging public-private partnerships to ensure affordable generic manufacture. I want to give one specific example for pediatrics, which is often a very neglected population. So the WHO hosts a network called GAPF, which is a global accelerator for pediatric formulations. And they have done various drug optimization exercises. You may know them for HIV and TB, for example. But they have also recently done one for childhood cancer, which was launched in March this year, and previously last year for antibiotics as well. And these are really important exercises that come from a normative body but are very inclusive of other groups that participate to identify key priority products and preferred product characteristics to expedite development of safe, effective, and accessible treatment options. Because we want to basically steer research in the right direction so that academics and developers know what they should be putting their research resources into, but also once a product is on the market, for supply and procurement, harmonization and coordination is very helpful for supply efficiencies and for better pricing negotiations. So in terms of the PADO outcomes for antibiotics, this is in the report. So there are two lists. The first is the PADO list. It's the shorter 3 to 5 year horizon for existing indications in children, but for which a suitable age-appropriate formulation is not available. So you can see the list there, one of which is cefiderocol, which is part of the GARD-P portfolio, and so we will be looking at pediatric development and access for that antibiotic. This is to treat drug-resistant infections where few other options are available. And then for the watch list, that's a longer year, 5 to 10 year horizon, and this is for antibiotics that are in use in adults but with no pediatric indication, or antibiotics still being studied in adults. And the list there also includes cefepime taniborbactam, which is a BLBLI in the GARD-P portfolio. It's not yet on the market, and we will also be developing that for pediatric use. Also, interestingly, PADO includes additional research priorities, so looking at older off-patent antibiotics that could be reinvestigated for other indications. There they have listed fosfomycin and flumoxif, and GARD-P will be looking at those to in a study design that basically ranks different antibiotics to find out which would be the best one or best ones to treat sepsis in newborns. The other example I wanted to give, this is the last one, would be expanding access through pooled procurement. So this is one of the mechanisms to improve supply efficiency and pricing. Secure, which is a partnership between GARD-P and the WHO, will be using this as one of their mechanisms, but also an existing example is the Global Drug Facility, which is part of the Stop TB partnership, hosted by UNOPS, and they already employ pooled procurement to improve supply of TB commodities, some of which are also in very low volumes, such as reserve antibiotics and antibiotics for pediatric populations would also be in that category. And so GARD-P has signed an agreement with GDF to improve global access to antibiotics. This will be for antibiotics that GARD-P is supporting. And basically GDF will use the know-how and capacity for these antibiotics that they have been using for TB commodities to date. So pooled procurement will be part of this. And that just serves to improve forecasting information so that suppliers and buyers are more coordinated in terms of the demand of the medication. And the pooling also allows regions to negotiate better prices with manufacturers as they have better surety of how many volumes will be procured. And this allows for better negotiations from both sides. Okay, and that was my example. Happy to take questions. Thank you.
And we're going to have Q&A at the end, and so more opportunities to ask more questions. That was really enlightening to hear about some of the potential solutions. So our last speaker, last but certainly not the least, is John Kirknes. So John Kirknes is the head of international affairs at the Norwegian Cancer Society. Previously, he headed the Department for Cancer Research, Prevention and Cancer Care. He's also been on a board for the Gemini Center for Sepsis Research. He has a wide experience in political advocacy, organizational development, and leadership. And John is going to bring it all together and talk about the political declaration. Thank you.
Thank you for having me. It's so nice to be here. And my name is John Kirknes, and I'm from the Norwegian Cancer Society, and we had worked with the AMR challenge for several years, since 2017, with awareness. And we have an own exhibition, we had an international campaign, so I really liked the film that started this session. Kristin, really good, and Sonali as well, and Shalini for doing this. I think it's very crucial. So what about the declaration that we had in 2016? Cancer is mentioned none, zero. So the cancer community was not part of this declaration. We have 8 commitments, but we could see that 2 of them have done some success, and that's because they are measurable and very specific. It's about creating national plans. It was national plans, like 93%, but that said, only 11 of them was financed properly. And we have this interaging coordination group on the AMR, who was the second commitment. But the 6 other commitments was kind of fluffy. But now we have more countries and organizations concerning about AMR. As you could say, in May this year, we had the multi-stakeholder meeting in New York, and we have excellent briefing papers, both from Andrea from REACT, and we have Wellcome Trust as well, and we have the Lancet series, and we have, of course, the supplements that several of you have worked with from UICC. It's great, and I was together with a lot of experts in a dialogue at Wilton Park, where also the 2 people from the UN who was leading the negotiations was drafting this zero draft. So we got input to the zero draft. And now you can see the EU and the Canadian flag, this joint health cooperation between the EU and Canada. And one of the 3 points, it's actually AMR. And I think that's a good thing. So we had great hopes, and we think that the zero draft, it was kind of good. And then when we got the final text, who will be presented next week at the UN level, it is watered down. So what has happened? We have also seen the second last edition on the 9th of August, and it's very little happened from 9th of August to 9th of September. But from 20th of May to the 9th of August, very much happened. But that was a silent process. So, yeah. So it means that governments, they are not actually ready to take the actions that we wanted. So The most disappointing thing that we think, that's it should be proper funding. We both need global funds and we need national funds. And you can see there are 100 million by 2030, and you should save millions of life. And it's an expectation that the national plan, 60% of them, will have funding. But is that enough? I think it's kind of unrealistic. So we have to see that it will be both funding at a global level, but also at the national level. And at the access part is very crucial, especially for low and middle income countries. And that's also a part that we miss, because we think UICC, the Swedish Cancer Society, the Norwegian Cancer Society, that the Lancet series were kind of good. Then you have the 2030 targets. And remember, it was the 20% target actually came from the animal sector itself. So why is it out? There are some big countries who are working with animal and food productions and so on. So things happened in the silence process. And there are also, like you mentioned, development of new antibiotics. There are, like the big pharma, you have the EU investment, you have Wellcome. They all chipped in with $1 billion, but actually the pipeline is not good enough to have actual development of these drugs that we really need. So we need to have this structure around it, and it was like this independent scientific panel as well. It was in the zero draft, but it's now out. So yeah, it's kind of weak, we think. And also the follow-up and accountability mechanism that we all want, but then you have to have real targets. And we think that it missed some real targets. And as you could see, also the UN Secretary General report midway, but now is that removed. So it's very much up to the nations itself to come up with a solution. We think we need global ambitious targets, and we need a nation who really sees the problem. And I had one note here because I was sent an email from Norwegian politicians, and he said to me about this declaration: if we are honest, perhaps not the best result, but positive at least, I guess we were able to reach a result at all, and with a small number of important commitments remaining. Thanks always for your support and for your advice. Apologies we could not deliver at best outcome. But remember, you have even a worst case will be not a political declaration. So hoping that this political declaration could be the momentum that we have this good implementation phase at national level. I think we need it. Because if you see the climate change, they have clear targets. They have a lot of money put into it. They have a good structure. You have the global HIV response mobilized 8.2 billion in 2023. And remember, you have the meager $1 million to save this big health crisis. So where is the targets? We need the targets. So I hope things could happen in New York next week. That have been fine. But I think it's all coming back to the question why. Why does the heads of state, the finance minister, understand that this crisis is really important to put both money and accountability and all that stuff into it? So I will end by thanking for the film one more time. I think that was perfect. So thank you.
Yeah, thanks so much. I think one of the challenges with AMR is the silent pandemic, as we call it, because I think all these issues are equally important, but I think we're missing the gravity of the crisis because it's really a silent pandemic, and it'll be good to see. I think a lot of people have mentioned, the need for patient advocacy and engaging the community. So we will open up now for questions from the audience. Okay, I'll get started. And please. And
I'll
can you
try
say
to
your
be
name
brief.
and your
Yeah.
organization?
Philip Mueller, I work for Hologic,
Mhm.
a molecular diagnostic company, at least the division I work in. I came here out of curiosity. I have really no big stake in AMR at this moment in time, but it's perplexing to me how such a big problem doesn't seem to get the attention. I think the last presentation was especially dire to me as an outsider coming in here. But I was wondering, none of you talked at all about diagnostics, since that is what I'm familiar with, in a way of maybe downstaging what antibiotics can be used for current infections as a way of controlling AMR in maybe even cancer patients. What perspective do you guys have on that, and what could be the use of diagnostics more broadly? Not just for the bugs themselves, but truly for the resistance mechanisms.
Diane? Yeah.
Yeah, it's a great question. So diagnostics are the critical cornerstone of any good antibiotic stewardship program. And if we want to reduce the burden of AMR, diagnostics need to be used more frequently globally. And there's really an access issue in many parts of the world. We talked about LMICs and lack of access to antibiotics. It's even more dire for diagnostics. So there was a study done in Africa by ASLM, which only 1.3% of the 50,000 labs they interviewed were doing bacteriology testing. Bacteriology testing is what's telling you what antibiotics are resistant or not. So whether that's by a phenotypic method or a molecular method, they were doing none. So if you start to think about the patients that are receiving chemotherapy care in those parts of the world, they have, there's estimates on how bad the burden of AMR in there, but they're not doing the testing. So we don't even know. And the clinicians have the challenge of not having data to manage a patient and don't have access to the right antibiotics. And probably the other thing that we didn't really clarify for the audience, and you may all know this, is that the antibiotic pipeline is very, very small. So why are those numbers I showed so terrible? Because the doctor will not have another antibiotic to choose. That patient will not have access to care. So that bug, there is no antibiotic to treat because there's no antibiotics being developed. So the antibiotic pipeline is very weak, and I think all the great work that GARD-P and everyone's doing is fabulous, because hopefully that will be improved. But for the short term, using diagnostics is a critical tool.
Andrea, do you want to? I think the issue of diagnostics is particularly critical in LMICs, and I don't know if you wanted to add to that as well.
Yeah, I can just briefly say something and I leave you. Yeah, definitely, like in my presentation, I mentioned medical countermeasures, and that, of course, includes diagnostics, which I also think it's a critical step, especially when we discuss about what type of antibiotics to use. So one of the causes of AMR is indeed that a lot of broad-spectrum antibiotics are used, whereas if we were to have, specifically in low-middle country, access to diagnostics, it would be much better because we would know what type of resistance that patient has, and then as a consequence prescribe the correct antibiotics, assuming that they would have access to the antibiotics. So I really think it's critical. I also want to mention that I believe end of May, beginning of June, the Longitude Prize has been, which is a huge prize, has been given to a diagnostic company in Sweden, in Uppsala, where I'm sitting. I don't have any credit for that, but I just want to mention that. And I think it's great because that hopefully will promote some good results in the diagnostic field.
Here. So I think all three of us used to come from labs, so we couldn't agree with you more, I think. I'm sorry I had to go through the diagnostic stewardship part a bit quickly, but just to say that although we are not developing diagnostics, we are working with countries to try to see how that can be programmatically resolved. One part we are not really working on is the community level appropriate use of antibiotics, which is more viral versus bacterial, and even with bacterial, the need for antibiotics. And there are other organizations such as the Swiss TPH working even on a clinical trial showing no worse outcomes with less antibiotic use at primary care level, for example, in Tanzania. But upwards from that, at district and especially district level, there are just no microbiology labs, and the capacity is not there, and the budget for procuring machines and reagents isn't there. And even if the budget is available for cheaper commodities, such as to do manual culture, for example, disc diffusion, people need to be trained in how to interpret the results. That is a big, big gap. It's almost easier to train someone to do manual culture than interpret the results where there are no clinical microbiologists or ID docs. And so some solutions though are available. MSF have developed Antibiogo, which is a smartphone-based application which actually automatically reads your disc diffusion results for you if you don't have automatic systems, for example, which are more expensive. But even those are being supplied through the Fleming Fund, and in the future also the Global Fund will be allowing procurement of more microbiology consumables. But it's such a small amount compared to the massive international support that we've seen for HIV and TB and malaria, so we have a long way to go. But we need it not only for patient diagnosis but for surveillance as well. We have big epidemiological gaps. Yeah.
All right. Any other additional questions? Yes.
Hello. Thank you very much for the really nice presentation you gave, all of you. I hope I'm not completely out of the topic, but I would like to ask your opinion about the bacteriophage as a potential treatment also for the resistance of this drug resistance, to overpass this drug resistance.
This is not part of the GARD-P portfolio, but I did actually recently watch a webinar that WHO hosted on this, and to date, no bacteriophage has been able to successfully get through a clinical trial or through registration. So that's a big hurdle. But also, it's quite personalized. So because these viruses target very specific bacterial strains, which can also change over time, but they need to be updated, and they also need to be used with antibiotics. They're not used standalone. So we should obviously keep looking at them, but they're quite targeted, personalized therapy, and there is nothing that's been approved by a regulatory body at this point. Would you like to
add a little more? So there's definitely companies, I'm from the US, so there's definitely companies in the US that are selling these specialized phages where if you have a critical patient, they actually send that patient's isolate to the company, and then they'll test their library of phages against it to figure out which one works. So they are available for use in critical need cases. And there's been some really good funding coming from some funders in the US to help support those companies to further the development of those. And there's been really good stories of success where you've seen cystic fibrosis patients who had multi-drug resistance help with their infections, as well as there's a very famous story about a gentleman who was traveling with a multi-drug organism and then was able to do the phage therapy, survive his infection. So I think it is one of the options we have as we build the portfolio to be even bigger to fight, because these bacteria are smart, right? So they're going faster than we are. So any technique we can use to slow them down would be great.
All right. Any additional questions? Yes, please.
Thanks so much. This was really interesting. I'm also not very, I don't do work in this field, so this was very enlightening. I just had a question about the multi-center study that was conducted. I mean, it's clear that cancer patients have an increased risk of AMR compared to non-cancer patients, but did you notice anything about the cancer types? Because cancer treatments change dramatically based on the specific cancer type that one is diagnosed with. And as a follow-up to that, did you notice any, if you had combinatorial treatments like chemoradiation, did you notice anything different?
Right, so great question. In this data set, we could have taken the different chemotherapy agents and bucketed them by use and then applied the analysis. We haven't done that yet. So right now we've just looked at the 283 chemotherapy agents on the NIH list of drugs. However, there was just a recent publication that just came out that looks specifically at ICD-10 codes. So in the US, that is a way that you can say what type of treatment a patient's getting, what is their diagnosis, and therefore their diagnosis was X type of cancer. And I haven't had a chance to read that paper yet, but that just was published. So I think there's some opportunity there, and there's lots of other great researchers. So one call to action, anyone out there that wants to do this sort of research is really important. We love to see this in other parts of the world and understand how it looks in other countries, and then for folks that have access to other types of data to understand per type of cancer what the impact would be.
Yeah, and I think that's a really good question, because I think we do know that patients with hematological malignancies are more likely to be affected. I think one of the surprising outcomes of your data was that we didn't expect the outpatient data to show as much resistance, because we assumed that patients who are admitted to the hospital likely have worse infections, they're going to have higher rates of AMR. I think what was shocking was that even in the outpatient setting, which is where we treat most of our solid tumor malignancies, there are even higher rates of AMR. And so I think it's important to think about the different types of malignancies, but I think this is really highlighting that for cancer patients in general, this is a huge problem. Additional, yes, please.
Yeah, thank you. I have a very selfish question back to innovation in diagnostics. So I want to get your perspective on an innovation that is coming, which is, imagine there is an FDA-approved triage tool that enables a nurse, a community health worker, to assess reliably bacterial versus viral through a picture taken by a smartphone and an AI engine at the back that tells whether the patient is viral or bacterial. So do you see that as something relevant, important, exciting, very exciting, or nice to have?
I would even say super exciting. So that is, I would say that's been one of the AMR diagnostic holy grails. I've been in the diagnostic space for many years. I work for BD, Becton Dickinson, where we develop a lot of these sort of diagnostic tests. Having a point-of-care test that can differentiate bacterial viral is critically important, but I would say as important as developing diagnostic test is developing the behavioral change that will need to happen to get clinicians to actually follow the test. So many companies have developed point-of-care tests for flu, and they'll do a flu point-of-care at the pharmacy, yet they'll still give a patient antibiotics. So it's how you develop the test and then the behavioral change, whether that's a carrot or a stick, to get them to also not give that antibiotic.
Okay. Sure, yeah, completely agree with you. I would say in low resource settings, it's been a bit more challenging. So I mentioned this was TPH, also find they are looking more at clinical decision support tools with rapid diagnostic tests added in. So you'd always have your malaria RDT as well, plus for non-malarial febrile illnesses that are not serious, you would very much benefit from a test like that. Right now, CRP is more available than, say, a test that had viral and bacterial markers. But we really have only been able to use that for the negative predictive value. It doesn't diagnose anything. It can't rule in a bacterial infection. It can only rule out a bacterial infection. So we are still looking for that holy grail test that is still affordable and accessible, because some of these newer tests have just been priced outside of the feasibility of domestic budgets for the most part, and have also not actually been validated outside of high-income countries all that much. And given they're usually measuring immunological markers, you can get variation in different populations with different background infections, co-infections, etc. So the validation more globally has been a big gap as well. You probably want to answer that question.
No,
too.
I was going to say, I like the fact that you mentioned affordability. I think you mentioned, part of your presentation had really focused on the fact that brick and mortar microbiology labs don't exist in a lot of low resource settings. And so I think thinking about point of care testing is going to be very key. But the big issue is it affordable? Because a lot of patients are paying for antibiotics out of pocket. And so if your diagnostics is going to cost more than your antibiotic, then you take the antibiotic without the diagnostics. And so I think these solutions we have to think about it within the lens of how can we scale it up? How can we make it accessible? But really good points. Any more questions? Yeah, okay.
Thank you very much for this integrated presentation on the impact of AMR on oncology. You've mentioned, how the political willingness is going to be important. And usually as we look at political willingness, you need the why, you need the how, and then you come to the how much, right? And so I wonder, how do you see this as where we are in terms of answering these at least two first questions before we come to the third one of how much we need from these ones?
John?
Yes, I think after today and after being discussion with someone, that we are still in the why. And I wish I could turn the clock 5.5 hours back. Then I will have this session in the main session downstairs instead of this forum fee F. And then I will combine. We are talking about the NCD high-level meeting next year. But AMR, this is it. This is 2024. So I have organized 10-15 minutes with the head session, and then everyone. That's how we could connect all the cancer community. I think we have still a work to do, and we have to work with the why, and I think the film is good and so on. So yeah, thank you.
Okay. Thanks. So we're almost up at the hour, and so I'm just going to go around because I think like you said, the UN General Assembly meeting is this September. It's next week, actually. And so if you had one message for political leaders on the importance of AMR, because we see that, the political will is not there, the targets aren't quite where we want it to be, what would your message be? And we'll just keep it brief. And Diane, you have the mic, so you can get started.
Yes, I'll start. I think it would be improved use of both diagnostics and medicines together will help the general population and specifically help vulnerable populations. So actually at next year's Zanga, I would like to see AMR on the agenda because we should be there. AMR should be there because if we know that we're undermining cancer care and if the Moonshot program is going to fail, let's just put it out there and let the cancer community help us, the AMR group, figure out how to do better at the why.
If I have to summarize, I'll say bold financial commitments. Definitely both when it comes to national action plans. So John was mentioning before the percentage of those that have been actually financed. So there is a huge gap when it comes to that. But also financing, I think all the work that both civil societies and communities are doing on the field. A lot of communities are doing work just volunteering, which is excellent, but there's also a lot of time of their life that are spending doing this. So definitely there is a need of financing and having a landscape of what's going on. Also just briefly mention to the question before, I think in a way we do have enough data to start acting. So we don't need to waste any more time. The time is now, we can't waste anymore. Thank you.
Yeah.
Thanks. Agree completely with what my panel members have said, and also just to reiterate that we have examples where we've seen bold political commitments, political will, and resources going into successful programs for HIV, for TB, for malaria, for example. We can do it for AMR, and it should be an ecosystem approach that addresses all of the needs at the country level and at international level also for a holistic success to happen.
John, you've been saying that the declaration is very watered down, so it's probably appropriate that we're ending on you. Can you let us know, what would be your ideal?
AMR is an international problem. You can't solve it nation by nation or private sector or governments or civil sector. So we have to find together and we have to rethink how we could take this from the political declaration to true actions, also like funding and So good luck to all of us.
Thank you. Can we give a round of applause to our panelists? Thank you so much for attending.